Thank you. Thank you very much, Professor Nguyen. And I just want to also, Jonathan and I were saying thank you so much to ASNA for allowing us to do this joint session of International Federation of Clinical Neurophysiology with ASNA. Okay, so I've been asked to speak about advances in neurophysiology in the assessment of peripheral nerve disorders. This is going to be fairly rapid because we've got a short period of time. And like what Professor Dunn said before, I will introduce some of the techniques that are emerging, but again, you want to put it into the context of the local setting. So I don't have any disclosures to the current talk. So very briefly, this is my overview. So essentially, peripheral nerve disorders, it is a big problem. Okay, 2.5% of the global population will suffer from some form of disorders of the peripheral nerve. So we know multiple causes. You've got your metabolic, particularly diabetes. You've got immune-mediated Guillain-Barré syndrome, CIDP, toxic neuropathies. So why is it important for us to understand what's happening? Because more and more, there are therapeutic pipelines that are continuing to increase. I think one of the explosion in therapy that we have seen, especially is in motor neuron disease or ALS. And similarly, we're also seeing the same in terms of managing peripheral nerve disorders, in terms of looking at pain, for instance, neuropathic pain. As a result, in any clinical trials of any drugs, you need to have good biomarkers. So biomarkers to see with the health of the nerve, so looking to see what the state of the nerve is and how it progresses, and also if you are going to introduce drugs, how it's going to change the characteristics of the nerves. And that's one of the reasons that it's important to understand what's emerging and what we have to try and help with this. So the peripheral nervous system, as we know, the nerve has got natural electrical properties that we can measure, and that is where neurophysiology comes in. So we're able to stimulate, we're able to record this electrical activity from individual nerves and also the muscles. These are by and large fairly accurate. You can reproduce them. And when you have reference ranges, you've got some published reference ranges, but I would suggest that each center also have your own reference range, because it does depend on ethnicity in terms of your settings and also in terms of age, gender. So it's good that each population have that kind of setup. So we know about nerve conduction studies. So this talk is not focusing on that, but basically the conventional nerve conduction study does do a lot already, okay? With that, you're able to localize the pathology. You can tell whether it's nerve versus neuromuscular junction versus muscle. You can determine patterns. You can determine extent of involvement and how severe it is. But unfortunately, there are limitations. So for instance, access is typically to very few nerves and also muscles that tend to be more distal. So trying to get to the deeper nerves, to the more proximal nerves and also the muscles, though there are issues with that. And also the other thing is there are limitations in terms of when a nerve degenerates and it re-innervates, you get this collateral re-innervation that happens anyway. So that makes your CMAPs not the best biomarker, because you would have to drop perhaps 50% of your actual function to be able to see that drop in the CMAP, because you've got this re-innervation. So as a biomarker in terms of drugs, for instance, you're not probably able to use CMAP, and that is where the issues come. Electromyography is also, just like the nerve have electrical properties, you've got the muscles that also have the electrical properties. And what we do is we analyze, this is the baseline, we know this, We look at spontaneous activity, we look at the motor unit, we look at the actual recruitment patterns. But again, limitations to that. It depends on your electrode, where you site it. It also is not reliable in terms of this large operator-dependent bias in terms of how you interpret the data. So the first thing that you can do is that based on what you have or what you understand of the nerve conduction studies in NMG, you can look into how you can make that better, build on what you already have. And that is some of the things that we're seeing coming through that is being used more and more. And that would be what I've put here, unconventional, and that is looking at motor unit number estimation and also quantitative EMG. I think you would have, these are fairly straightforward things if you want to move, from what you have that is standard. And what this does is to better try to quantify and also to try and make it a little bit more precise and a little bit more reliable so that if you are intervening, you can actually see what the changes are. So what is motor unit, MUNI? So what it does is it estimates the number of motor units in a muscle, or sometimes they use an index related to the number of motor units. And it assumes that your CMAP is the supramaximal electrical nerve stimulation, and it's reflecting single motor unit potentials. So when you have a CMAP, so if I just show, I don't know what I can do. Let's have a look. Okay. So if you look here, okay, this is something that you would see that was normal. So a CMAP, you've got all of this multiple individual units that make up the entire CMAP. And this doesn't necessarily change if you were just to do straightforward nerve conduction studies. But with MUNI, the idea is to try and identify the individual units that you, through this, there are a couple of platforms that you can do that. So this is AMSCAN, and there's also another one by Sanjeev Nandikar called STEPIX. And the idea is, if you have a normal study, so this is looking at normal versus motor neuron disease in this case, you find that there is this smooth line. But if you were to look at diseased nerve, you find that actually, it's not that smooth. You see these steps that is picking out individual nerves. So for instance, if you look at the AMSCAN MUNI, you'll find that actually there's only 23 nerves here compared to what would look as normal. But if you were just to do a CMAP, you would just get just one CMAP. So the idea is looking at this breakdown, and this is something that's automated. So you'll get MUNI that will give you individual estimation of the motor unit numbers. And there's multiple methods. So it started off with using incremental and then multi-point. And these days you've got AMSCAN, Munix, MUSIX, STEPIX. And more you'll find that there are machines, new machines, more advanced machines that got software that is able to allow you to do this. And although this is subject to the limitations of standard nerve conduction studies, it is much better than just doing your CMAP because it allows you to look at the individual motor units, and in patients longitudinally following them up, you're able to see if you were to use a drug, whether or not that's improving, whether they have more regeneration. And if you were looking at ALS, for instance, you can actually look to patients are actually using the motor unit. So you see here, so in diabetes, and this is in acute motor axonal neuropathy, which is the axonal form of GBS. And just by doing this, you realize that actually, the CMAP doesn't really change in the first few weeks. And when you do the MUNI, you find that it actually stays the same. And that suggests that there is early collateral sprouting even before you start seeing the regeneration. So these are really important in terms of understanding the pathophysiology and also in terms of intervening with treatment. So next is quantitative EMG. So similarly, but you're now looking at EMG. So again, how to quantify it better. So when we do EMG, you've got your needle there, you've got your central spike, and you've got your slow wave components. if you were to, I mean, you can do it manually. I mean, it'll take forever if you do it manually. So, and you don't have that kind of time. So what there is now, again, just like Muni, there are platforms and there are software that's able to now automate. And the idea is to be able to look at these individual motor unit potentials. And then really what this is useful is looking at probability of myopathic versus neurogenic through analyzing these trains and also looking to see how quickly you get the interference patterns. And how do you do that in terms of clinical application? So this is what, when you do an EMG, this is what you would see normally, okay? And these are the sort of reading if you're looking at turns, turn versus amplitude analysis. And it makes sense, if you had a software and you would, with the advance of artificial intelligence, you would be able to see that your turns are much higher when it comes to myopathy, but the amplitude is obviously much, much smaller in myopathy. So you'll find that it's at this end that it's actually populating. And conversely, in neuropathy, you see that the amplitudes are much higher, but the turns are much smaller. So the idea is that to be able to develop more software to be just automatically looking at the patterns and looking at probability of whether this is likely to be myopathy or whether it's likely to be neuropathy. So these are kind of the application that's currently emerging. So another interesting one is high density surface EMG. I mean, surface EMG, if you put a surface electrode, you can pick up EMG potentials. But the idea here is to use a high density. So it looks something like this, and it's non-invasive, which is very attractive because it's not painful. And you've got multiple channels, it's a fixed grid, and everything is being recorded in parallel and comes up with something like this. And if you look at this image here, it does compare quite well between, needle EMG here, you've got, it's maybe the resolution is not as good, but you are picking up here voluntary activity and also spontaneous activity here as well. So it is comparable in that sense. And the idea is that this is using software, looking at advanced processing of individual motor unit action potentials to see whether or not you're able to recruit better after treatment or with the disease progression. So this hasn't been as widely, but again, emerging. And one example here is in inherited neuropathy, which is in Charcot-Marie Tooth. This is by the Japanese group, Yuichi Noto and colleagues. And what they did was place the high-density surface EMG on the proximal muscles. So this is on the thigh muscles. And interestingly, I mean, it's not the results that even they had expected, because the idea is that with neuropathy, you would expect that the firing rate would actually increase. However, what they were finding is that it had a lower firing rate, similar to elderly patients that had this utilized in patients, older patients. And they wonder whether there is re-innovation that's causing this. And at 1 year, they found that the motor unit firing rate was significantly decreased at the beginning of the sustained contraction. So again, this is not validated as yet, but just to, potentially something that is not invasive in terms of the EMG that could potentially be utilized. Okay, not sure what's going on there. Did something there? No, we need to move the next slide. Okay. So I think all of you would have heard of nerve excitability or threshold tracking techniques. So what we've talked about in terms of nerve conduction studies is looking at, the velocities, it's looking at differentiating between axonal, demyelination. So with threshold tracking, you're looking essentially at the properties of the axonal membrane. So we know that, you've got this propagation of the impulses relies on your nodal saltatory conduction, okay? And you've got at the nodes the sodium, potassium channels, and also you've got the slow, the fast channels. So the idea is that changes in threshold would reflect changes in the membrane potential. So these have become more interesting in terms of understanding disease pathophysiology, because if you understand the disease pathophysiology, then you can figure out, what sort of treatment would be helpful in patients. So using a fairly, comprehensive setup, and I'm just going to disclose here that I don't do threshold tracking myself. I mean, this is, again, specialized machines, specialized, software. But the idea is that, so you get your maximal CMAP, and then you're giving an unconditioned test stimulus, and you're looking to see, keeping 40% of the CMAP is what your target is. And you're seeing what is it that's required to track this target response to keep it at 40%. So that's essentially what they're looking at. And these are some of the parameters of the nerve excitability that they look at. So these are some of the patterns where the software actually produces and comes up with the graphs that gives you an idea of the depolarization, the hyperpolarization, and the threshold electrotonus here is what one focuses on, and you will see here what each of these parameters indicate. So it tells you with regards to whether there's persistent sodium conductance or whether there is, dysfunction, as you see here in diabetic neuropathy. So one of the patterns that's picked up is this fanning in phenomena, which suggests that there is sodium-potassium pump dysfunction, which is something that's seen in diabetic neuropathy. And you might find that there may be persistent sodium conductance if it is a nerve excitability status, like something like ALS, for instance. So this has been used in a lot of clinical application in terms of understanding and interpreting what are all these different diseases, what the underlying pathophysiology or what the underlying membrane potential changes are in these different diseases. I'm not going to talk too much about ultrasound. I put it here only because this is something that is also more and more being used complementary with nerve conduction studies. It's something that certainly we use in our center. And there's a couple of speakers that's going to do that. And you'll see that ultrasound in CMT certainly allows you to differentiate between the CMT patients. Quantitative muscle ultrasound is something that our group have done, looking at, again, CMT patients. We've also looked at Guillain-Barré syndrome. So all I wanted to say is that, at the end of the day, there are lots of things. I've picked out a few that you would have heard of, a few that, so that you have an idea of what it does. But at the end of the day, and certainly in our setting, certainly in my setting, because, working in Malaysia, resources are fairly limited. So conventional neurophysiology continues to be your gold standard. And where possible, you want to be able to utilize that to understand disease better. So for instance, a lot of the work that we've done is looking at serial studies in Guillain-Barré syndrome, serial studies in other inflammatory neuropathies, and that already has given us some idea without having to do any of the fancy stuff. But if you are going to do anything, and only because I'm a little bit biased maybe, but this next speaker, nerve and muscle ultrasound is, machine is not that expensive. I managed to pick it up, and if I can learn that, I think most people can. So I think that would be the next thing that you would add to your, your tools. Muni and quantitative EMG, it still relies on you acquiring, still high quality equipment to get the automated programs, and also you need some skill in interpreting this. And it's not impossible, it can be done, and hopefully that will be your other step. But the rest that I told you about, the threshold tracking and the HD high density surface EMG, those I think for quite some time will remain research tools and probably not something at this stage validated to be used in terms of clinical practice. And with that, I finished my talk, but I wanted to, seeing that we're all, advertising for our conferences. So the first one is next month. We're hosting the Asia Pacific ALS conference in Kuala Lumpur. So please, for those of you who are interested, we've got some fantastic speakers, so do come to that. And of course, please do come to ICCN next year, where you learn, for those of you who are interested in the research tools, you can hear something about that, but we're also going to be offering lots of the straightforward conventional stuff, also the slightly more advanced courses. And there are, for those who want to submit proposals for the symposia, well, the deadline for that is end of this month. So if you feel like, there's topics that you really want to submit for consideration by the Scientific Program Committee, do so. And thank you very much.